Um, okay, I can't hear you.
Can you hear me now?
Yes, I can hear you. You
Okay.
can try
Yeah.
your screen share if you
Okay,
want.
I'll do that.
Is your video on?
No, no, no. I have
Okay.
not started my video. I'll just share the screen.
Okay.
Uh, I think they're asking for some app to share, which I don't have. I'm using the browser. Can I log out and come back again, please?
Okay. Yeah.
Yeah.
Good morning, everyone. Hope you're all safe and sound. Welcome to the second day of PsyCoV-22, National Seminar on Psychological Impact of COVID Pandemic. While we are waiting for our guest, I'll just brief on today's morning session. We have a keynote address by Dr. Kamala Rammohan, followed by a panel session on disability management during the pandemic.
Dr. Kamala, I can see you have joined. Are you able to screen share now? Dr. Kamala, can you hear me? No, she's gone. Hello, Dr. Kamala, can you hear me?
Rajni, I can hear you. I'll try sharing my screen.
Okay. We can see your screen.
Yeah.
Okay.
Is it visible now?
No, we can see you, but we can't see the slides.
Okay.
Okay, now we can see you also. Okay.
Is it visible now?
Yes.
Okay.
Just before we begin, before we hand over the mic to Dr. Kamala, here's a small introduction to our speaker.
Dr. Kamala Rammohan is a familiar face who have featured in Vogue as Woman of the Year 2021 for her professional contribution during the pandemic. She is currently working as Assistant Professor in Pulmonary Medicine, Government Medical College, Trivandrum. She has worked as Assistant Nodal Officer, COVID Cell, MCH, Trivandrum. Dr. Kamala is a team member in the special medical team constituted to set up COVID facility at MCH Kasargod. She is also technical team member SWAAS SWAS Kerala COPD Control Program Technical Expert Kerala Clinical Establishment Act 2018. Over to you, ma'am.
Thank you for the kind introduction. Good morning, everyone. First of all, let me thank the organizers of this national seminar on psychological impact of COVID pandemic, which is organized by the Department of Psychology, University of Calicut, and most particularly Dr. Rajni Ramachandran, who's been a very close friend over the past, maybe since childhood. So I think I'm not a psychologist. I think you understand that by now. I'm a medical doctor, and in the next few minutes, I'll just share some of the experience that I have had over the past 2 years dealing with the COVID pandemic. As a clinician, I've been dealing with patients and, of course, with their caregivers at various levels. And I can share a few experiences that and the concerns that were raised over the by my friends, and other than the patients, my friends, relatives, and others who I have interacted with over the past 2 years. And so, more than we worry about the disease and its repercussions, there are a lot of psychological impact, as you might be knowing better than me. So I'll just move on to my the topic that I've been given. That is a perspective from the front line. As you all know, in December 2019, a cluster of pneumonia cases of unknown origin was recognized in Wuhan, China, which led to the discovery of a novel coronavirus, that is the SARS-CoV-2, which has now undergone a series of variations, and it has not remained a simple infection, and we are still dealing with the long-term sequelae of this infection. So, by the constantly increasing numbers of cases outside China prompted the WHO to declare COVID-19 as a pandemic on March 11, 2020. And if you look at, these are the statistics that I could access couple of days back. And though Kerala did not, when compared to the global issues as well as the issues which the other states of India had to deal with, Kerala has remained more or less stable over the months, except for a spike in cases during the second wave, which resulted in comparatively higher deaths. So, if you look at the graph, the second peak or the second wave was from probably May to July, and I think I was the COVID nodal officer from the period from July to end of October, and that was when the probably when the crest of the wave was coming down. So basically, I work in a tertiary care center, and the spectrum of cases that I've been seeing is different from what is there in the community, and sicker patients with a lot of other issues. So maybe the impact has been more for these patients than and their relatives than for the people in the community. So now we are almost, we are hoping that we are coming down in or towards the tail end of the third wave, and we expect normalcy to be back by March, or at least that's what the experts are saying. So what are the we all know that a lot of disruption has happened due to COVID, and the major domains which involved include social, occupational, a great deal of health issues, psychological issues, family disruption, and also economic issues. And the vulnerable groups or the vulnerability areas that have been described are in the elderly and poor with chronic or even acute ailments, the migrant laborers, people stranded in locations other than their own home. That is, people have traveled, or the expats have come for the their vacation. They couldn't go back, losing their jobs. Then people who traveled even within the country and who were unable to travel back because of the travel restrictions. Then the senior citizens, when the concept of reverse quarantine came, these people, this group of people were, their freedom of mobility and everything was curtailed. And even I think most of you can relate to that. Our parents are being cooped up in the house without having an opportunity to interact or speak to others, and then the fear of infection, because these are the most vulnerable group once they get at least with the previous variants like Delta. These people were at more risk. Then the quarantined individuals and their own their issues, even though most of them were quarantined in their homes or in a public facility, they had their own health issues as well as psychological issues. Then the issues with regarding the families of those suffering or even quarantined. So what I understood is that the issues of all the age groups are slightly different, and even though the children and adolescents per se were the least affected during the even the three waves of the pandemic, there were a lot of they had to undergo a lot of trauma, because the schools were shut, the activity was their activity was restricted, everything was confined to a screen, even interaction with their friends or their studies, everything was confined to a screen. Then the inactivity, physical inactivity, they were not let out to play games or any kind of sport, and this also led to a lot of health issues, weight gain, obesity, then emotional issues, and then the constant use of the computer or the mobile phone that causing many other issues like recurrent episodes of migraine or headache or visual disturbances, all that. Then they had to deal with the parental conflicts, because some of them, some of the parents lost their jobs or they were made to work at home, and then they were continuously monitoring their children, and because of their own emotional issues they would be trying to control their kids. Then in the marital discord and domestic violence, that these issues also increased during this pandemic. And the disease itself, when the parents died, the Lancet study, which was a modeling study done 2021, mentions that almost 15 lakhs of children were orphaned globally, and in India itself it was 1.2 lakhs. Then separation from their parents, when they fall sick, many of them were asked to stay in other houses, and when they fall sick they were separated from their parents. And then there were increased episodes of abuse online, as well as and even though there are situations where I think you might be familiar with the term multi-inflammatory syndrome, where the COVID infection per se does not produce much of a health issue, but later it causes severe systemic diseases in the children. In adults, it's another picture altogether. In the second wave, the first wave actually took away a lot of elderly with comorbidities, like patients who were on dialysis, or they had significant other major medical illnesses, and the mortality and morbidity was more in that group. But from what I saw during the second phase, it was more of younger adults, like persons from 40 to 60 years. They came with infection, probably because they were the more exposed people. Some of them were still working even though there was a lockdown, and then they came with severe pulmonary infections and complications, and long prolonged hospitalization and related issues, causing financial burden. When these people were put in the governmental institutions, I think probably the cost of treatment was lesser, but a lot of them had to access private healthcare, and then on top of losing their jobs, they had to shell out a lot of money for treatment. Then the loss of loved ones, family members, loss of their jobs, lack of peer interactions, a lot of even visiting your family was not there. Then all those people who had to travel to make a living, they had to cut down on their travel, and that resulted in a lot of jobs being lost. Then another thing was they were confined to this online mode of communication, and all the meetings probably shifted to online mode, and this led to sedentary lifestyle, obesity, and those people who did not do a regimentalized or who did not move on to a change in lifestyle, which included some sort of activity, it resulted in other medical issues as well. And I think coming to your topic of interest, that is, most of the studies mentioned that there were more than a 25% increase in depression and anxiety. And even though there was less access to alcohol and other stuff, there was still increase in substance abuse, and a very high increase of domestic violence. And some of the papers even go on to say that the intimate partner violence increased up to in females it was almost 1 out of 4, and in males 1 out of 10. And the elderly was a special group that like for example, when I sit in the OP, a good number of patients used to be above 60 years with their own medical conditions. So these people had to be at home. They were not permitted to come to the hospital because of risk of infection. That resulted in worsening of their chronic conditions, lack of immediate medical care. And another thing is they could not. There was delayed diagnosis. What I could see in my hospital was that when the restrictions were sort of relaxed at some point of time, all these patients who were at home for 1 year, they came with a lot of complications, like a delayed diagnosis of malignancy, stroke patients at home, uncontrolled diabetes, hypertension, cardiac diseases, everything. And as you might know, the elderly, they have a lot of emotional needs, and one of the things that I've noticed with people coming to my OP is that they need somebody to talk to. So just even though they used to get their regular medicines for diabetes or hypertension in the local family health center or primary health center, they would travel all the way to the medical college OP to see their, the doctors whom they are familiar with, so that they could just talk. So that component was lost. And then the scare of infection, with the scare of infection, they were restricted at home as well. Then another aspect that I noticed was because loss of job was there, and the adults or the younger adults in the family could find less time to spend with them because they were worried with their own issues. Then the lack of income, that was the more money would be siphoned off to other expenses, and they were not taken care of. The elderly were given lesser priority. Then there were cases of domestic abuse. What I saw while I was doing my rotation in the COVID cell was that during the second wave, the lot of elderly were admitted with complications, and the only communication was through phone to their family members. And when we made attempts to, when they were fit for discharge, and we made attempts to call the bystanders or the family members to so that we can discharge them and send them home, we realized that most of the numbers that the phone numbers that were shared were wrong. And it turned out that people, the elderly who were more than 90 years or 80 years, they were not, they didn't want to take them back. And we had to, on some occasions, we even had to trace out their homes with the help of police and take care of them. So these issues were there, and it was really heartbreaking to deal with these people. And they were at one point of time we didn't have any bystanders looking after these elderly, and our medical college staff, they were looking after them, and they all needed personal care, to help them to go to the toilet or to change and all that. And they were all fit for, most of them were fit to be taken home, but nobody was coming to take them back. Then like I already mentioned, less access to healthcare, and then because of inability to go to the nearest health facility, there was a poor control of the non-communicable diseases. So I'll just move on to my experience, like from where I started till March 2020. I think we were dealing with only very few cases. Even one case, you can maybe recall all the hue and cry when one person turned positive. There was a route map being published. Then we used to avoid all the places that person had visited during his course of infection, and there was a big promotion and all that. So it was during. Can I continue? Okay, so now when we look back, rise in cases up to 100 is not so significant, because even a CF or a first line treatment center might have even 100 patients in one place now. But at that time, when the number of cases was very few, the number of cases in Kasaragod district went up to 100. So then, as a proactive measure, the government, as a dynamic response, they decided to send a medical team from Trivandrum. Actually, they were planning to send teams from all the tertiary care centers. So we were the first ones to be chosen, and we were asked to go as a special medical team to set up a COVID care facility in the district of Kasaragod. The whole country was in lockdown. But in Kasaragod, it was triple lockdown because a lot of people had traveled from outside, and the number of cases in the community was spreading. And Kasaragod is a district which has less facilities and resources compared to the other districts. So now I think if you look around, people go around without fear, without any mask, they think, oh, it's only Omicron, it's only a milder variant kind of thing. But at that point of time, the concept regarding the infection was not clear. We didn't know what we are dealing with, how the infection would turn out to be, and we wanted to contain the spread. And all the team members, including myself, we didn't know what we were going to deal with. There was a real lack of motivation, and the fear level was very high. But still, we were given a task, and our team members included 13 doctors, 10 staff nurses, and 4 assistants. And we were very efficiently supported by the government, the Kerala Police, Transport Department, district level administrations, NGOs, etc. And the mission we were given was to set up an exclusive COVID care facility at the administrative block of the Kasaragod Government Medical College, which was not yet functional. There was we came to know all that only when we were midway through the journey, and by the time we reached, we were told that we have to set it up within 24 hours because the other hospitals or facilities in the district were almost full. So this is the bus that we traveled. It was a low floor bus, and which is rather uncomfortable to make a 16 to 18 hour journey. That's the minister, Dr. Shaniba teacher, who flagged off the trip. And so this is the block, the medical college block on top of a hill, very desolate looking place. And in the background of the triple lockdown, there was hardly any inhabitants in the nearby area, and it was a long winding journey uphill with no facilities, no hotels, nothing. Everything was closed down, and anyway there was nothing, no institutions or houses or any hotels nearby. So we were asked to make this area into a hospital. So these were just rooms for officers and labs for the students, or proposed labs for the students. So we made out a chart, and we didn't have any areas to cordon off the patients from the general area. So what we had in abundance was some metal cords. So we made up walls with this cords and cordoned off the patient area so that we could the people or the other staff could work in safety. You can see corridors made out of these cords, and this used to be the patient area, and beyond this is the exit area, and we had to use these cords again to close off because the none of these so-called wards did not have any toilet facility or anything, and these patients could not be allowed to mingle with the rest of the public. So that's the concept we had then. Now I think many of us are asymptomatic and positive, and we are asked to work without any quarantine. So this by God's grace, we were able to finish the getting out of the hospital within 24 hours. But we had a lot of issues because there was power outage, the poor water supply, poor sanitation. We had to make a 1 hour journey from the place where we stayed till to the hospital, and taking duties. Then the patients, they were all very scared. They were all dealing with the first of a kind of thing, and they were very scared. So their anxiety turned out into aggression. They were making demands for all sorts of things. And the food that was supplied, we didn't. There were only community kitchens at that point of time, and the food for the patients as well as for the staff and the doctors came from these places. And though we did not make any compromises on the patient care or what the food to the patients, most of the times people taking duties had to go hungry because there was food shortage. And then each time we got in, we were scared whether we'll get infected and whether we'll be able to come back, all those things. But finally, this is my team. So we were able to manage the situation, and we were there for almost 2 weeks, and the next team came to relieve us. But that's just a short story. And after that, the real pandemic kind of came into action, and then we've had waves, smaller ones and bigger ones over the next months. So my experience would be that the impact, though the cases in Kerala were comparatively lesser when compared to the other states, we did not have the crisis that Delhi or the northern states went through, or even Tamil Nadu or Karnataka went through. But the impact on the non-COVID patients, their issues, their medical issues were not addressed. They had less access to care, their delay in diagnosis, all those issues were there. Then impact on health infrastructure and facilities. Most of the existing facilities were turned into COVID care facilities, and they were all, it was not a planned move. Whatever we had to open for this, to take care of these COVID patients. So then the health workers, they were I think the police, health department, and probably the LSGD. They were the ones who were actively involved in dealing with these issues. So the fear of infection, stress on them, their own, because I can imagine, I know what I went through, because to protect, our primary concern was to keep ourselves safe so that we would not infect the family members or our friends. So that was taking a toll on our mental status, kind of always living in fear, and then depression when somebody falls ill. I think I've seen a few of my friends falling ill twice or thrice, and quite a few of our friends and family lost their elderly parents during the mostly during the second wave. Then there were cases of hospital violence, people staying at home, then coming with the patient. They were not, they were worried about what would happen, and their worry and anxiety would turn into some violence in the hospital, which would be taken out on the hospital staff. Another issue that we could notice was that the cost of care, especially there was no regulation regarding, initially at least, so a lot of people got away with making profit out of all the fear and confusion. And over the months, even though we've had very bad cases of the disease and its sequelae, what we can see when we look around is still non-compliance of the public to COVID protocols. And initially, when the scare level was high, we were all very careful, at least most of us. Now, if you look around, there is nobody is taking any precautions in spite of warnings. So there is attrition of safe practices. So we have to actually change our mentality, and getting depressed or anxious without taking the necessary precautions is not really worthwhile. So I'll just mention briefly about what we have. I think most of you may be aware of this state program for mental health that is called Ashwas. And the mental health program actually came up with a concept called Kerala Oppa. So this program or this initiative is actually designed to assess and improve the psychological well-being of these isolated and quarantined persons, their family members, selected vulnerable groups, and health personnel and frontline workers. And they developed customized interventions, and this program was rolled out from February 2020. And the psychosocial support team actually reached out to the public to provide services by actively contacting them by telephone and services through a helpline number. The team was led by a nodal officer and included psychiatrists, social workers, psychologists, social and counselors. And though the initial interventions were more for psychological needs, later with the advent of lockdown, social needs were also increased. They didn't have caregivers, access to essential items. Those were also addressed. And this initiative was also supported by the regular staff of the district mental health program in each district, counselors from the ICDS, and ICTC and National Health Mission and volunteers. The program actually classified the needy into 7 groups, that it's the mentally ill patients who had less access to care. So then children with special needs, they were also neglected and they were difficult to manage. They were difficult to manage at home. Then the elderly, persons with alcohol dependence, school children, health personnel, and also the guest laborers. So this is just an algorithm of how the program worked. They made a list of persons in quarantine. The proactive calls were made to these people and assess whether they have psychological needs or social needs, and they were dealt with accordingly. So there was an initial assessment of the benefits of the initiative, and they have demonstrated that this helped in alleviating the uncertainty about the disease and the management and the situation, averted a lot of psychiatric emergencies, suicides, etc. Then even now there is a lot of misinformation going around. So the counselors or the people who interacted, they could dispel a lot of this misinformation, and also the family also benefited from this initiative, because the persons undergoing or going through emotional or psychological trauma were given enough support by these counselors. So just highlighting, there are a lot of positive, there are a lot of negative aspects about the pandemic, but if you focus on the protective factors like positive thinking, spirituality, family support, and community support, the outcomes are good. So how do we go forward? That is, I would suggest, I think most of you might be knowing more about this, but still, strategies to stay mentally healthy, that is, can engage in routine activities, develop a regime to stay healthy, indulge in hobbies. Many of my friends and colleagues, they all started, they suddenly realized that they could paint well, they could dance, they could sing, all those things. The online platform was flooded with TikTok videos and all that. They're all good for cheer you up and give a positive feeling. So staying connected through social media, talking to friends, then avoiding substance abuse, keeping physically fit, yoga, all those things. And I think the help from the government's perspective, a multi-pronged approach towards healthcare delivery would be needed, with mechanisms for surveillance, reporting, and interventions. A lot of advisories regarding dedicated to psychosocial and mental health, a model to deliver holistic healthcare, and existing the public health systems should be strengthened and provide uninterrupted access to critical services. So I think I'll conclude my talk with this. So maybe if you, I'm free to take questions. Thank you once again, and I wish all the very best for the conference, and I hope that, I'm very sure that this will be a very informative seminar. Thank you.
Thank you, Dr. Kamala. We'll move on to the question and answer session. We have a few questions from offline participants. Audible or not? Can you hear me?
Yes, ma'am.
Dr. Kamala, can you hear me?
Yeah, I can hear you.
Just a second. Now there's a bit of an echo here.
Now I think I can't, did you ask the question? I did not hear that. It's a bit blurred.
Hello?
Yeah. Did somebody ask a question, Dr. Rajni?
Just a wait. Hello. Can you hear me now? Okay, we have a few questions. First one is, can you give a little bit of detail on the struggles within different stratas of healthcare workers? Was there a difference that you saw?
Yeah, okay, yeah. Actually, concerning the healthcare workers, there are, the people who take care of the basic needs of the patients, like, the nursing attendants and all that. They had to deal with the patient's requirements, like, most, like I mentioned earlier, most of them were elderly who were admitted. Then, because of their multiple comorbidities, some of them had stroke, some of them have had cardiac issues. Many of them were, many of the patients who came with illness during the second wave were patients on dialysis, chronic kidney disease, who could not be, who could not access medical care elsewhere, and they needed somebody, a personal care, and this was possible only, in a tertiary care center. It was where we could not accommodate the bystanders as well. This was all looked after by the nursing care nurses as well as the nursing attenders. So they had to work. Their stress level, I think, would be much more, because they were leaving their loved ones at home, and they had to wear these protective kits for a long duration of time. Then they had to lift these people up. Some of them would be obese. Then they would have to take them to the toilet whenever they wanted. They have to personally feed them, and that was, working in a very the staff shortage was very much there, because many of them fell ill at that point of time. Because when we move around with the pp kit and then do physical activity, uh, often there is some breach of the pp, and you are exposed to risk. And the nurses, and the doctors who were taking ICU duties, even though we were in PP, and initially there was no designated time. Some of them would have to stay for longer periods. So all those things and regulations came at a later point of time, and then taking long hours of duty in the PP kit, and then there is increased risk of infection in the ICU. Sometimes when an emergency comes, you may not be able to take adequate precautions, just rushing to save the patient, even though you're trained to make sure that you are protected and then go attend the patient. Most often when the patient crashes, you just go in. So these kind of issues were there. And we were then there was the non-covid side. But any patient coming to certain specialties, at least like mine, or an ENT person, or any patients dealing with respiratory infections, they even other specialties, they would be sometimes the bystander might be positive, or sometimes the patient might turn out to be positive. So this risk was always involved. Then the surgeries, emergencies would be posted, then the patient would turn out to be positive, then the whole lot of doctors and staff who attended to the patient will turn out to be, positive next. So these issues were there. I think, did that answer your question?
Yes.
Yeah.
Thank you. Another question. കോവിഡിൻ്റെ തുടക്ക സമയത്തെ ഭീതിയും ഇങ്ങനെ ഒരു ഡ്യൂട്ടി ഏറ്റെടുക്കാനുള്ള മോട്ടീവും എന്തായിരുന്നു? I'll translate for those non-Malayalis. Initially, during the time of COVID outbreak, we all were in pain. What was your motive, or how did you take up that tough job?
Oh, did you mean the Kasargod trip, or is that what you meant, ma'am?
Yeah.
Yeah, okay. So actually, I think the thought process, or the motive was, you were asked to take up something. That is what we are trained for, and when there is a need, a genuine need in the society, most of us just decided to go. Of course, the fear factor was there. A family were trying to tell us, don't go, make some excuse, but most of us readily agreed to take part in that mission, because that would be doing something for the society. I think that's what we are trained for.
Another question, പേഷ്യൻസിൻ്റെ കൺഫ്യൂഷൻസ്, അവർക്ക് അസുഖത്തെക്കുറിച്ചുള്ള അറിവില്ലായ്മ, ഇതിനെ എങ്ങനെ മാനേജ് ചെയ്തു? കാരണം ക്വാറന്റൈൻ ക്വാറന്റൈൻ പരിചയമുള്ള കാര്യമായിരുന്നില്ല. ഐ ട്രാൻസ്ലേറ്റ്. ഡ്യൂറിംഗ് ദ ഇനീഷ്യൽ time of quarantine and COVID outbreak, patients were really confused and they didn't even know how to manage it. How as a medical health professional did you manage the anxiety which the patients have shown?
Yeah, thank you for that question. Actually, one thing that all of us had to do was, the information that was coming in was confusing even for us, the medical professional as well as the experts. They were just getting, and we had to filter through what is, what proportion of it is right and what is wrong, and then only convey or pass it on to the people who were coming to us, whether it be friends or family or even our colleagues or the patients and their relatives. So, but we had to update almost daily, because a lot of work was going on regarding this novel coronavirus. But we used to update ourselves and then pass on the information, allay their fears about safety. Actually, what I have understood regarding the disease over the past 2 years is that a properly worn mask is enough in most situations to help protect you. That's what I have understood. And I think the guidelines over the past months have also changed in that direction. Wearing a mask is probably the only thing that can protect you, and anything that happens, whether whenever our health professionals get infections, it's mostly because there are breaches inside the ICU, or when there's slight lack of care, or most often from our family members or from our colleagues when we take off the mask, when we are at our when our guards are down. That's what I have understood. So this message, I think, was conveyed to all the people that we came into contact with. At least protect yourself, then protect your family. The safety practices. We used to describe all that to people who came to us. And regarding quarantine, when we used to send these initially, what happened was we would ask these people to stay in quarantine. So their concept of quarantine is just staying in at home, but interacting with the people at home. That is not the concept. If you are in quarantine, you have to be in one room, and so that all your needs are met from in that room and not mingle with the rest of your family. So initially, this concept was not very clear, I suppose. But over the coming months, it was drilled into their behavior, but still it's very difficult to change behavior patterns, and that's what we are seeing in the community.
Thank you, ma'am. Another question, ഇപ്പോഴത്തെ കേരളത്തിലെ സിറ്റുവേഷൻ എങ്ങനെയാണ്? What's our current situation?
The current situation, I think we are moving on to normalcy from what the guidelines are coming. The government is taking a attitude so that the loss of opportunities, loss of jobs, and the loss of wages to the at least a good section or good proportion of the community is not acceptable anymore. So we have to go back to normalcy. We do say in medical college, if I look at the cases during the second wave, it was like the inpatient number with COVID was in 1,000, nearly 1,000, and just maybe a little bit above. Then it's kind of slowly came down. Now we have around 100, 150 maximum cases admitted there, and most of them are admitted because of their other issues, like a person with heart disease coming in and being tested positive, just like that, not because of COVID and related issues. So we have to assume that the severity of the infection is lesser, but that's not that's not the idea. that you can lower your guards. You always have to protect yourself. You'll never know. So if they say that Omicron is a new variant, it will just go away with an upper respiratory infection. But you never know which variant you're going to catch, whether it's a Delta or an Omicron. So why take the risk? You have to be careful. But yes, I think we have to move on to our move back to our regular work and normal living.
Another question. I hope we can take one or two questions more. One world, one health. Your take on this approach?
One world, one health. Yeah. Thing is, I think the pandemic, my take, as you have told me, it's made the world smaller because even though we are in different parts, the psychological and the health issues we dealt with are very similar. If you look at the WhatsApp messages, and I mean, all your preconceived notions about Europeans and Americans and other people and Indians, and the country-wise variations are almost, the people behave similarly, and their health issues are also more or less similar. So I think a uniform approach to health should be there in place. More hygienic ways of living, regimentalized exercises, exercise, patterns, and good eating habits, hygiene habits, etc. So that should be a unifying thing for all people all over the globe.
Hello, ma'am. Am I audible?
Yes.
Ma'am, I have 2-3 questions for you. Ma'am, the first is related to, in your experience, what do you think is the role of superstitions? People have many superstitions and misconceptions in the time of COVID especially, and this has popped up. And how has misconceptions actually influenced the management of healthcare? And one question related to this is, certain practices, sticking on to certain homeo medicines, or then, following home remedies, and then, following to these kind of practices rather than taking a medical support when they are in crisis, and then they are reaching you with in a very worsened condition. So how do you, so what do you have to say about these kind of experiences?
Actually, this experience is not new to me. I mean, it did not take COVID to bring this, experience, because people come to us only after they have tried all sorts of home remedies. I'm not looking down upon any other specialty of medicine or anything, but they generally, the concept of the public is that allopathic medicines or modern medicine, I would rather say, are very strong medicines. So it should not be given to children. It should not be given in the initial phase, and they try all sorts of things, including the local what do you say, some tribal medicines or whatever, local physicians and indigenous practitioners. They all have their own expertise. But sometimes, most often the small cold and cough will go away with these medicines. But a good number of real issues and medical conditions are often neglected. So we are used to seeing this. Like for my specialty, I would say that asthma is a very, it's a disease that can be controlled, and a person with asthma can live a normal life. So when the patient comes to us, if his or her normal life is disrupted with frequent exacerbations or frequent hospital visits, and they are not able, even the children are not able to go to school, the people, I mean, working men or women are not able to go to office, then they come to us, and then we advise inhalers. I'm just citing an example. The general thing is, they are very resistant to this type of medicines. They think it is very powerful medicine, and you cannot. All modern medicines are very powerful, and you cannot take that. So that kind of attitude exists even for COVID. So they try all sorts of things when the oxygen saturation. So one thing that you have to note for COVID is that there's something called happy hypoxia. The oxygen level falls, but the patient will not feel anything. until a critical level when the patient might just collapse. So then they are brought to the hospital to us in a very critical stage. So it's really upsetting. Something which could have been at least managed at an earlier level in a better way comes to us in a later stage. So we do see that even before COVID this was there. And I would suggest, the even though there is a lot of awareness initiatives going around, still even the very educated Malayali is very suspicious. I'm limiting to Kerala. I don't know about the other things, but we are very very suspicious group of people. So, but still, we'll go blindly to some other very unscientific thing and then come back when things worsen. That thing is there, but we try to manage it as patiently as we can. Try to talk to them, reason out the need for our medicines, and that's how we go about it.
And then some officer has to, these kind of issues we see, and
Yeah. Actually, all these things come up because pardon, I think that last part I didn't hear. Yeah. Yeah, we are also like the first, when we deal with aggression in the hospital, it's like normal for especially younger generation, or even it's normal to get defensive, and that can be in many forms. But as far as possible, you should know that sometimes the casualty or the ward, it's very hectic. So when we have time, we do spend time to reason out to them the need for care. Most often what happened, like you mentioned about the maggot issue, I think I just mentioning my take on it. When there are a lot of when you are wearing a PP kit, it's very hard, very difficult to it keeps fogging. As being a person who have, I mean, I've worn it, so it keeps fogging, and even when you scribble notes, it's very difficult to see that. So looking and caring for people, I'm not saying that it's the proper thing, but still sometimes you may miss, and it's not very easy for wounds to get infected. So those things happen. I'm nowhere justifying things, but when these people come, as much as possible, we try to reason out. Sometimes we may not be able to give individual attention to patients when the casualty is crowded, or when there are a lot of cases coming at one time into the ward. So then that is the time when these things happen, and we can't really blame the bystanders or the caregivers, because they might be worried about the patient, and that's probably their first reaction. But often one thing what I have found is that most of them, at least during the pandemic, when there were we asked for bystanders to take care of these patients, risking at the cost of risking, we were ready to, they could buy a PP kit and stay with them, but most of them refused. So, people who are not really ready to take up ownership, then coming and blaming the medical personnel for lack of care is not really, very fair. We used to have, I think I remember one case where we had a patient in our pay ward. So his son was earlier in the initial days, the son was ready to stay with him, but later he tested positive. Then he started blaming us. I don't think that's a very fair situation. We told the person that the risk of infection is there. So, but you have to take precautions, and if you want to take care of your father, you can be there. Then after a while, when he really turned positive, we started. Those things happen. So now we are more or less anticipating all those things and going by protocol. Yeah, if you look at it, I think good number of patients who have been infected. They get away without much complications. At least a proportion of them with pre-existing conditions like heart disease and other comorbid conditions, they might have other complications. So what I see in my specialty is something called the pulmonary fibrosis, or that's the most distressing complication that can come up. But we do get patients who have excessive fatigue, persistent cough, and headaches, sleeplessness, loss of appetite, extending up to 2 to 3 weeks, or maybe a month or a couple of months after the COVID infection. So we generally advise these people to stick to a healthy diet, do regular breathing exercises, and watch for any warning signals like developing limb edema, like leg edema, retractable cough, then breathlessness on exertion. Those things have to be taken seriously, and you have to get checked. You probably might need an X-ray or a blood investigation to check whether your floating parameters are normal. Then excessive fatigue also, which persists beyond a few weeks, then it's better to get investigated. Am I audible? Yes. Yeah. Psychological preparation would be like, most days it's like, we are dealing with, in my specialty, we were dealing with very active cases. So just mental preparation is go out, do your job, don't get infected. That's what that's the only thing that was in my mind. And then trying to keep as not positive in the disease perspective, but in a positive state of mind as much as possible. Connect to your family members, and stay calm. That's all that I've been doing over the past couple of years. Thank you.
Okay. Thank you all. Good morning to all. Welcome to the panel discussion section as part of the PsyCoV 2022. Thank you so much, Department of Psychology, for organizing this 3-day national level seminar on significant theme, psychological impact of COVID-19 pandemic. Today we have a panel discussion on important theme, disability management during the pandemic. In this discussion, we will be talking about the impact of COVID-19 pandemic on the life of person with disabilities. We will be also discussing the important topic of disability inclusive pandemic response, an initiative done by various agencies in the field. As you know, COVID-19 pandemic is one of the biggest psycho-social economic crises of our generation. It has created numerous challenges to all domains of our day-to-day life. More importantly, it has adversely affected the life of marginalized communities, such as persons with disabilities. Persons with disabilities are often vulnerable to neglect and exclusion in the time of crisis, in any type of crisis. Pandemic systematically intensified the exclusion of persons with, particularly the social exclusion of persons with disabilities, and they are more marginalized group in the crisis affected community. Even under normal situation, PWD often experience exclusion in the terms of access to healthcare. They have a limited access to healthcare, education, employment, and participation of community living. They are more likely to be in the situation of poverty and experience high rate of negligence. COVID-19 situation have further worsened this situation and adversely impacted the life of person with disability both indirectly and indirectly. In this context, today we are trying to explore the impact of COVID-19 pandemic on the various domains of person with a disability, such as disability management, rehabilitation, schooling, employability, and the social inclusion part and the social life and the experience of being with the person with a disability. We also explore their experience of their parents, how they manage their children during this period. We will be also discussing the various disability inclusive pandemic responses initiated by state government, national government, and international government. So let's begin. Today we have a group of well-experienced panelists. They have worked extensively in the various sectors of disability empowerment initiative. They are also contributed significantly in the area of disability inclusive response during the COVID-19 pandemic. So without much time delay, I'm happy to introduce for the first presentation, I'm happy to introduce Dr. Anilkumar, Research Officer, SCERT Kerala. He is special research officer to the person with a disability and children with a special need. And during the initial period of pandemic, he was actively involved in the preparing lot of COVID disability friendly initiative for the person with children with a special need as a part of SSA Kozhikode district program officer. Then secondly, we have Mr. Denny Davis. He'll be talking about the care and therapy of children with disability during the COVID-19 pandemic. Thirdly, we have Shaniba J T, special educator and vocational rehab specialist. She'll be talking about the topic on special program for young adult with a disability during the COVID-19 pandemic. And fourth, we have Dr. Mridula, a representative of parent and caregiver group. So she'll be talking about the caring the children with a special need during the COVID-19 pandemic and caregiver experience. And lastly, I'll be talking about the various disability inclusive responses happen initiated during this COVID-19 pandemic. I'll be explaining few best practicing model. So I'm happy to welcome Dr. Anilkumar A K, Research Officer at CRT, for presenting his thoughts and experience. So Anilkumar sir, floor is yours, please.
Thank you, sir. Can you hear me, sir?
Okay, sir. Please.
Okay. Good morning, everybody. I am Dr. Anilkumar from SCERT. Today, I am going to present about the education of the differently abled children in the pandemic situation. Before starting my presentation, I like to say a few words about the education department. Next slide, please. Okay, thank you. Our the education department in Kerala contains 14,000 plus students and 1 lakh 60 teachers. 1 lakh 60,000 teachers are there. And the main thing is that according to the performance grade index, PGI index released by the Ministry of Education, Kerala has the highest grade A++ during the year 2019-20. And again, one other state is Punjab. So in the 2020-21 also, we have got the highest grade PGI index. This shows that the Kerala is giving more importance to the education, and we have achieved a human development index comparable to the developed countries of the world. The society attaches so much importance to the education. The PGI index shows that we are the Kerala community, or Kerala government, the Kerala educational sector is giving very much importance to the education of our children. Next slide. Next slide, please. Okay. Now we are going to discuss about the education of the differently abled children during the pandemic. As we all know, due to the COVID-19 situation, the schools were closed. So the conventional system of education, that is face-to-face interaction with the children and the peer group teaching, etc., were blocked. Schools were closed. So the government has decided to start regular classes using the digital platforms. So all the classes are converted into digital classes. So the government has introduced first bell videos. The name of the digital classes introduced by Kerala government is First Bell. So they have introduced First Bell videos, and it's given to the children on the regular basis through Victor's channel using in the television mode in YouTube. On the regular basis, they have given it these classes in the regular basis. Government has utilized their entire technological support for creating these videos. They have used augmented reality, animations, virtual laboratories, feeling of a direct experience, and all are included while creating these First Bell videos for the children. But after 1 or 2 months, it is found that these videos are not suitable for children with special needs. One thing is that it's very suitable for the children with specific learning disability and also for the slow learners. Because when we say about, for example, Jallianwala Bagh, in the digital platform, they have shown the short video films about the Jallianwala Bagh. So the students got direct experience of the Jallianwala Bagh, and sometimes we talked about the pyramids, mummies. Then they shown the direct pictures. So the students got a direct experience. So the visual learners benefited from that. And also the children with a specific learning disability got ample opportunity to see the videos again and again and again. And the parents can see the videos and can support their watch. But when we talk about the children with intellectual disabilities and hearing impaired, visual impaired, and children with autism, these students are not benefited so much from the First Bell videos. So after the review, the government has decided to start adapted video classes for children with special needs. So they have designed adapted video classes. Adapted video classes means adaptation done in the content area, in process, in teaching learning materials, and also in the area of evaluation. In these 4 areas, adaptations were made, and adapted videos were made for 6 categories: VI, HI, CP, ASD, ID, ID. And these video classes are given to not through the television channel, but through YouTube channel and specially designed website. A special website were launched for these purposes, and through websites we have given it to the end user, to the differently able children. We due to the non-availability of the channel, we can't give it to the television through television channel because there are 6 different types of categories are there, and too much videos are there because when while we are creating videos for an intellectually disabled students, we want to create to achieve a learning outcome. We want to create 3 or 4 videos. So number of videos are very large. So we can't give it through the television channels. And after the review, it is found that these videos are not suitable for children with visual impairment, especially for the totally blind children. So we have started talking text or audio classes. Its name is talking text. In Malayalam, it's called Shabda Padangal. And we have created talking classes for every adapted. Actually, it is an adapted audio lessons for the visually impaired children. And again, the whiteboard videos are not very much suitable for the children with intellectually challenged children. So we have started digital worksheets for these children. Next slide, please. This is how we started the process. First we started first bell classes, then we started whiteboard videos for the differently abled children. Then we started the audio classes for the auditory learners and totally blind students. And after that, again, after the review, it's found that for some students, face-to-face interaction is highly essential. They are not so much benefited from the digital classes, and the learning gaps are very high. We have conducted 2 or 3 studies about the learning gaps, and it's found that learning gaps are very high for certain differently abled, in the group of differently abled children. So we have started special care centers, and in upcoming slides, I will talk about the special care centers. Next slide, please. This already I have explained to you that whiteboard videos are made for 6 group of children categories: VIHI, ASD, CP, ID, and SLD. And now there are more than 2,000 videos, adapted videos are available in our website, ssa.kerala.in/IE. These videos are available to the parents and children and also for the teachers. Next slide, please. This is the flow chart how the whiteboard platform is working. And the videos are created by the block resource centers. There are 168 block resource centers in Kerala under Samagra Shiksha Kerala, and every block resource centers are creating whiteboard videos, and these videos are edited by district level group and state level group, and final editing is done by, final screening is done by SCERT. And after SCERT is screening, these videos are uploaded in our website and in YouTube channel. From that YouTube channel, these videos are taken, this link is taken by the special educators, and they are giving it to the small WhatsApp group in the school level, and sometimes in Telegram groups is also there. And they are again adapting these videos for the children according to their individual needs. And for the parental empowerment program and for the social inclusion program, we have started Jalagangal Kapura. It's a training program under whiteboard whiteboard section, and I will explain it in the upcoming slides. Next slide, please. Okay. As I already mentioned, these whiteboard videos or the adapted videos, the adaptation is done in the 4 areas: content, process, teaching, learning materials, and evaluation. The special educators are very familiar with the adaptation process, but they are not so familiar with the digital side. They are found to be digitally illiterate, as we all are illiterate at that time. We are not familiar with how to use the Google Meet platform, Zoom platform. We are not so familiar. In the same way, the special educators and the special school teachers are not so familiar with how to use the Google Meet platform, Zoom platform, Google Docs, Google Sheets, how to edit videos, how to make brochures, how to make digital worksheets, etc. They are not aware. So we have given training to all the special educators in the Kerala state and all the special school teachers. We have given training to make them digitally fit. After giving the training, they have started to make videos. But the main drawback at that time, or now it's even now itself, is that we are not the system or the government is not provided camera with high quality, or we are not provided studio setup and upcoming years. So we are planning to provide very highly very high camera with a high quality to the special educators for taking the videos. Now they are taking these videos and editing these videos by using their own mobile phones. So when compared to the possible videos, there is some problems about the quality of the videos, not about the content, but about the qualities of the videos. Next slide, please. Next slide, please. Okay. I have already mentioned about the talking text for the auditory learners and the totally blind students. We have converted our textbook into adapted audio lessons, and we have created digital worksheets for the intellectually challenged children, and given in our website. And also, it's also available in YouTube platforms. Next slide. Next slide. As I have already mentioned that during this pandemic period, we have already decided to adapt the videos. We have decided to create talking text worksheets. So our general website is not more suitable for these purposes. So we have designed a special website for only for inclusive education. For uploading these contents. Life skill development contents are also available in these videos, but these life skill development videos are not made by education department. We have the main major content is provided by CDMRP, CRC, Composite Regional Center, and CDC, Child Development Center in Kerala, and other agencies are giving videos for life skill development, and we have included it in our website. And for the educational purposes, the videos are made by the education department. Next slide. Next slide. Hello. Next slide, please. All these are how it appears in the website. The talking text worksheets, how it appears in the website is shown here. Next slide. Okay. While I explaining about the milestones, first was well, then whiteboard videos, then talking text, and after that the review meeting and some research findings shows that online platform is not much suitable for the children with certain types of disability, especially for children with intellectual impairment, ASD, for HI. These videos are not so much effective. So we have decided to start face-to-face interaction as far as possible, whenever it is possible. So we have called them, the students, in small groups, in a group of 5 to the special care centers. So special care centers, specially designed special care centers are started. Next slide. Next slide, please. the activities in the special care centers are monitored by the self-government local LSG members, local self-government members, and special educators are giving IEP, ADL skills and social skills training in these centers. And the specialist teachers under our section is giving training into music, drawing, and work experience areas. And the general school teachers are working in the co-teacher system mode in these special care centers, and parental empowerment programs are also given through the special care centers. Actually, the special care centers are not fully functioning now. We have established it with a view that the digital platform is not so suitable for the children with special needs, especially with the children with the ASD and in intellectual impairment. And the learning gaps, the studies shows that the learning gaps are very high than we expected for children with special needs. Some special efforts are to be taken to fill these learning gaps. So we have prepared, we have started special care centers, and the schools are fully opening after February 28th. These centers will function in a full-fledged manner. Now there are 1,250 plus special care centers are established in all over Kerala, and teaching learning materials are already provided for attaining the basic skills in mathematics and language. And we are trying to provide table tablets, television sets to all these centers. There are 1,250 centers are there, so the amount need for these purposes is very high, and we are trying to collect it from the several CSR agencies. Next slide, please. And another program, I have already talked about the whiteboard videos, purely about the classroom purposes. And we have at the same time we have started the Jalagangal Kapuram, a twinning program for the to ensure the social interaction or to keep their self-esteem in a very high level. We have started a twinning program. So as I already mentioned, we have 168 BRCs are there, and these 168 BRCs are twinned into 82, and we have given ample opportunity to children to express their talents before the public and get appreciation. So the stress level of the students may decrease through these activities, and classes of experts from various areas, social justice department, women and child development department, therapists, counselors, etc. were given through these platforms. And successful job entrepreneurships that are suitable for CWS and children with special needs also were shared through these platforms. We have given training to the parents how to use the online platform for the empowerment or to support the children with the special needs. All these things are done through this Jalagangal Kapuram program. Next slide, please. Next slide. These are only examples. Next slide. And while discussing about the school-going children, another group is there. Some students, some children are bedridden, and they are kept in the four walls of the homes. So we have decided to support these bedridden children. As all of you are psychology students, you know that the bedridden children or the children are divided into three groups: the children with custodianship, educable children, and trainable children. And we have given special teaching learning material kits to these children. For educable children, we have provided 2,000 tablets so that they can see the whiteboard classes. We provided them in the whiteboard video classes in pen drives, and so that they can see the whiteboard video classes without using the network. or the data, money for the data. So we have provided the tablets, and appropriate softwares were all installed in that tablets, and especially designed teaching TLM kits were provided to educable children, so that parents can teach their words. The online instructions were given by special educators to the parents, and they are teaching their words using the TLM kits already provided to them. And another type of kits were provided to the trainable children, and for the recreational purposes, as you all know, the children with the custodianship we can give only the recreational activities. So for the recreational purposes, we have given radio with the pen drive, and we have given stories, musics, etc. To these bedridden children during this pandemic, because in the normal situations, every Wednesday, the special educators have to visit their houses once in a week. But during this pandemic, it's not possible. So we have decided to give the teaching learning material kits or recreational kits to these bedridden children. Next slide, please. During this endeavor, the CDMRP, a branch of CALICUT University Psychology Department, has supported us, and we are very thankful to the all the agencies of CDMRP and the Psychology Department. They have provided us 1,200 TLM kits from NIPIT, Secunderabad, Chennai, and CDMRP has given online training using these kits to the parents of the intellectually challenged children, and they are all these children are using it in an effective manner. Next slide, please. These are the activities that I have already mentioned: whiteboard videos and the talking text worksheets for ID students. Samiksha means the training in Braille to the visually challenged children. Mudrika Padam, training in sign language to the hearing impaired children. And it's all these things that I have already mentioned. Next slide, please. Okay, next slide. Next slide. Okay. The main challenges that we faced while doing all these activities is the closure of the schools is as we all know, that the schools are closed. It is a main great problem to the teachers. The teachers are work from home, and in the conventional, in our pedagogy is social constructivism. Our textbooks our curriculum is formed on the basis of social constructivism. So collaborative learning, cooperative learning, peer group teaching, all are essential for achieving the learning outcomes. So the closure of the schools made the main challenges. And second thing is that the digital illiteracy or limited knowledge of the parents, teachers, and also the students. So we at first we want to make them literate in a certain level to make use of the digital platform. So we have conducted DGPT training to teachers and parents. And another thing is that lack of gadgets like television, smartphones, and tablets. When possible classes are provided in television through television channels. So at first, in the first 3 or 4 months, the survey has done how many students have television sets and smartphones, and after that, it's found that many students have not smartphones and televisions, and the government has provided television set to almost all the centers. But even if we have provided the television set, as I already told, the digital content for the differently able children is not provided through television channels, but only through the YouTube channel and websites. So for that, smartphones and net, very good internet connection is essential, and a lack of internet connection and a lack of data, lack of money, etc., created problems for the children with special needs. lack of digital study materials. We want to create it from starting from one. We want to create everything from the beginning itself. So we are not so equipped for that. So that was another challenge. And as I already told you, that whiteboard video creation is not finished. It's already going on. Only 80, almost 80% is completed, and 20% yet to be completed. And limited data package for the availability. When we also we may use 1 GB data per day, 1.5 GB data per day, but in some families, 2 or 3 children are studying in the high school classes. They also need data. So after the one or 2 hours, it may exhaust the data. So the marginalized children or the deprived children in every home, the differently able children is sometimes deprived, comes under deprived category when compared to the other children. So they get least priority for the classes. So limited data package create the problems. Network issues, especially in a region with low internet speed, created problems to us. Students without access to internet were cut off from these classes, especially in the tribal area, coastal area. They have no access to the internet connections, so they are cut off from the classes. So that's why we have started the special care centers. Unemployment of parents during the lockdown period created many problems. So they have no financial, that they are not sound enough to give proper recharge for the net data. So that's also created problem for us. Mental stress and depression of both parents and students. So we have faced many problems because the socialization process is blocked, the peer group support is blocked, teacher support is blocked, and violence in homes and other job problem, etc., affected the mental condition of the general children, or also for the children with disabilities also. Loneliness of children, lack of socialization. Next slide. And you know that the school is closed for the last 2 years, and learning gaps is very high, and than we expected, especially for the children with special needs. Therefore, got all the skills and knowledge that they have already achieved 2 years before. We have supported them through the whiteboard videos and talking text and worksheets. We have supported, but as I mentioned already earlier, that the main problem is of network availability and one-to-one support. This created main challenges, and learning losses of children, CWSN, due to the school closure are very when the closure are very high, and when teachers, parents, and counselors and special educators jointly have to jointly work together to fill these learning gaps. That's all from here. Thank you.
Thank you, Anil sir, for your very extensive and impressive presentation. So we are moving to the second section. So if you have dear audience, you have any queries or comments, we'll be taking the after the presentation of all panels. So now I'm inviting Mr. Denny Davis, physiotherapist, CDMRP. He'll be talking on the topic of care and therapy of children with disability during COVID-19 pandemic. Mr. Denny Davis? Yeah, welcome.
or tele app method or other gadgets which we were using. that was very much challenging for the children, that is the end users, for the therapists who were giving the trainings, and also for the caregivers, that is the parents or the bystanders who were treating the children at the time of the pandemic. So, the next slide. So, as Sir was saying, I would first come to the point of the challenges that was faced by the therapists, the clients, that is the end users, and the parents. The first and the foremost thing was that the delayed realization on the need of the tele-rehabilitation method, or these methods, because at the first time of the lockdown, the children and the parents were all at home, and there was no contact with the therapist and the caregivers or the children. So that was a sudden stop, and after that, all the community came to awareness that we have to find an alternate method, and that was a delay in the time. When the realization happened, there was a lack of facilities. As it was said, the therapy equipments, the facilities that are available at their home for doing the therapies, especially as I am a physiotherapist, I think in that manner. So the availability of the therapy equipments was a major issue at the time of starting of a therapy tele-rehabilitation methods. And other thing, as said earlier by Dr. Anilkumar, the communication devices and the network errors was other major thing that was keeping the distance between the therapist and the clients and the children. So as it was said, the network, the lack of availability of enough data package, and the lack of availability of the communication devices, that is the tablets, the smartphones, the televisions, and also the parents were not able to use all these equipments to the apt method so that the children get the benefit. The other one thing was the reduced experience of the therapist in the tele-rehabilitation method. During the time of tele-rehabilitation, we conducted a study among the physiotherapists, especially because I am a physiotherapist. I did in the field of physiotherapy. Mainly the thing was the therapist was not aware about the outcome they had to expect through the tele-rehabilitation method. So the scoring of the non-usage of tele-rehabilitation method among the physiotherapists and the other therapists was very high. And because they were using mainly for only differently challenged children, but the elderly patients and other were affected in many ways, according to the study which I conducted. And the other thing was the difficulty in the communication strategies. So as a therapist, we use many terms and many methods. One or the other, we change the treatment methods. So when the parents or the caregivers are giving the treatment, it was difficult to change the strategies of giving the therapies to the children. In a way, the spasm of the children, the mobility of the children, to keep them. When we give stretching or other exercises, we have to change into a play therapy method or other methods. That was the same thing that was affected, that was a difficulty for the speech and hearing therapist and other occupational therapists and all. They were having a communicational difference and difficulty to convince the parents how to alternate the methods. The other thing was the level of acceptance from the caregivers. That was a major issue because the caregivers were giving a bit of negligence at the time, at the earliest starting period of the tele-rehabilitation methods, because all were expecting for the end of the COVID or the pandemic in a short period of time, but that was going to be a longer gap between the therapist and the end user. So the level of acceptance was very reduced at the starting time from the caregivers. But later on, they started to cope up with the things, and we were able to communicate with the caregivers. The reduced experience of the caregivers, that was another issue. But in our CDMRP, where we were using a parent-mediated method earlier from the starting of the CDMRP, that was 5 to 6 years back, when we started the CDMRP, we were using a parent-mediated method. So that was helpful to a level to those parents who were doing the method, because we had a larger community. So I used to teach them, or the therapists along with me, we used to teach them the method of giving the therapies at home, and how they have to maintain the attained achievements, so attained the functions that has to be maintained. So those parents were able to maintain the therapy methods. That was useful. But then also the other parents who were not able to get into that that flow of experience was reduced for them, and that they found it difficult to give the therapies, and we have to do a regular follow-up. The cooperation level of the children during the homely atmosphere. As we, the therapists, we always know that the children will be very lazy at home. They cooperate very less with the parents or the caregivers. Mainly if the grandparents or other elderly people are doing that, they use all the tantrums and other things to get out of their therapy modalities. The other thing was the difficulty in reassessing and reprogramming the therapies which we were giving. So as a therapist, when we find it difficult to attain a certain level of progress, we do a reassessment or we reorganize the whole program. So that was very difficult at the time of pandemic. Next slide. And I will talk about the challenges the parents were facing, because we had a talk with the parents after the time of COVID, after the time of pandemic. So the challenges, main thing was the tantrum of the children. So they were not allowing the parents to do the many of the things, mainly the motor skills and all those things to be achieved. So it was difficult for the parents to give the therapy sessions. The lack of skill, as I said earlier, the lack of skill and lack of awareness. At the first, they were not aware about the importance of the therapies that they had to do, the home training methods they had to do. But later on, when they started doing it, it became a bit more difficult, because there was a little relapse in the progress that the children had made. So that was a difficult thing. The other major thing was the income and the insecurity among the parents. Like they were having the financial problems, they were having the health issues. Even the parents were affected with the pandemic, and the other members in the family were affected. So they had to vacate the house. They had to, when the children were affected with the pandemic, they had the difficulties. The other difficulty in getting the medicines, the regular medicines, all these things were a challenge to the parents, because they were not able to communicate with the society or with the, but to a level we had to coordinate with the district DMO and all that, and we were able to help out many of the parents through the tele-rehabilitation method and other things. The facilities that were available to the parents, that include the therapy materials, the other things like the network and the gadgets. All the things were a challenge for the parents. The availability of the data, the usage of the accessories, and all those things were a challenge for the parents. Next slide. What were the challenges for the professionals? So main professional challenge was the attention. That was the attention of the child. That was the main thing that was said by all the professionals. So I'll be repeating that. In the field of special education, sir was telling that, Anilkumar sir was telling about the difficulties they faced, like for the children who are blind or the special need children, in the method of teaching them. So getting their attention to the place where we need it is very difficult, And that was a major thing, difficulty faced by the special educators during the time. The using of the smartphone, the other things like downloading the needed videos, the ability of the teaching by the parents. So many of the parents, when they are a bit uneducated or when they are not exposed to that teaching method, so they were unable to communicate with the children or get the attention of the children or keep on with the level of education the children had got. And so that was a difficult thing for the special educators to communicate even with the parents and even with the children. And other thing was the network problem. That was a major issue. Like the network available for the therapist as well as the children, because the therapists need to communicate with all the children available who were taking treatment under them. So the network delay and the network data package was a difficult thing. In the occupational therapy, the fine motor skill training was a difficult thing, because the fine motor means the hand usage, the usage of the functions. That was a difficult thing for the occupational therapist to do. Again, the attention of the child to develop the fine motor skills and other skills, we need the attention of the child. That was a major issue. The communication to the children with ASD and intellectual disability, was a difficult thing for the occupational therapist. So there was a relapse seen during that time. Next slide. The physiotherapist, as I'm a physiotherapist, explaining the functional movements or the techniques and the corrections was a difficult thing, how to communicate with the parents. We were not able to use the terminologies that we used to do. So that was a difficult thing for the explaining how to do the movements, the usage, the intensity of giving the therapy. When we are giving a stretching or a passive movement for a child with lower limb difficulty or spasm, that was a difficult thing to grade the movement, how the child should be done without irritation to him. That was a difficult thing to communicate with the parent. The reassessment after the session, the progress that have been made by the child, or the progress in the function achieved by the child. It was a difficult thing to get in touch with the parents, to explain to the parents in the initial sessions. The non-cooperation of the child was another thing. The motivation of the parent, that was an important thing, the motivation of the parent. How to motivate them to keep the therapy, because when they do, the pain of the child and all the things was a inhibiting factor for them to stop the therapy. So that was a motivating them was a major issue during that time. In speech therapy, the oromotor training were the therapists were doing with the hands, with the oromotor function and the training. That was a difficult thing to get the parents done with that. The sound modulations, how to pitch the sounds, how to make them produce the sounds, all those things were difficult for the speech therapist, because the voice that the speech therapist was expecting was not able to be communicated to the parent. The reduced parental training, many reasons, like the therapist used to do the therapies for individual therapies to the children previously to the pandemic on the individual basis without the presence of the parents. So the parent didn't know how to teach the child about the speech functions. In psychological psychotherapy and counseling, the parent inability to have the personal skill to educate the child, to control the child, all were difficult. So that is not, that will be more explained by Raheemudheen, I hope. And those were the difficulties that was faced. So the major relapses, next slide, ma'am. The major relapses seen was in the motor functions. As I'm a therapist, the spasm the power, the agility of the child, everything was reduced after the pandemic when I started to come to the clinic. So even before that, I was giving aquatic training for the children. The children who had achieved the balance in 2 to 3 weeks of training, they lost the balance in 1 to 2 weeks. And the parents were unable to get it back with the home training program. The vestibular learning, the lack of equipments, the vestibular learning, vestibular teaching, there was a greater and very much evidently that was shown that vestibular relapse was there in many children. We are trying to overcome, still we are trying to overcome that relapse that had occurred. The social interaction and the eye contact of the children had been reduced after the time of pandemic and after the time of tele-rehabilitation period. The learning disabilities of the children had been reduced. The speech deficiency, as I said earlier, was mainly in the children with comorbidities and other oromotor difficulties. That was very much evident after that, at the time of pandemic. So what were the, next slide ma'am, what were the other problem-solving methods? The problem-solving methods, next slide ma'am, especially was the medium mode. As Sir said, they had developed in the SCERT, they had developed many methods. We can go to the next slide. In the slide, I have shown that the video mode, that is a screenshot of the CDMRP website. So in that, a generalized video training videos and a personalized training videos were very much important at the time of a pandemic. Generalized video training methods, what we were doing is for general rehabilitation needs, the orientation for the parents, the motivation. We were able to do only the general things in the generalized training videos, but it was very important for the parents to get personalized training videos. Each children were different and they needed individual training and individual assessment. So we had to send them through WhatsApp and other modes to them, the personalized training videos, the correction they had to make, the method of holding them, the children, the carrying the children, all this had to be done. Next slide, ma'am. The other thing was the regular follow-up. We had to make a charted method, and that was a good work from our liaison officers. So here, this is another screenshot of the charted method we were following. Like the liaison officer was guiding us, guiding each. We were not giving therapies for the children who were visiting our center at the time of the pandemic. We had to go to the tele rehab under district collector, where we had to include all the therapists all over the district, Wayanad, Calicut, Wayanad, Malappuram and Kannur, all the district we had to coordinate that. So the liaison officers under us was working day and night to get in touch with all the children and their parents. There were a large necessity from the parents to they were calling day and night for how to do it. So the liaison officer was guiding the parents to contact which therapist they had to contact, and at the timing of to contact them, all those things had to be charted. So that was a difficult thing. Next slide, ma'am. The larger group of professionals was needed at the time of pandemic than that previously we were doing only we were giving service only to those children who are visiting our clinic or who are in contact with us. But at the time of pandemic, we had to take care of a larger group. As the other clinics in the private clinics were closed down, all the who were taking services from other centers started visiting our websites and our WhatsApp groups. So we had to take care of all of them, and so the association with the other professional groups We had to get centralized various association, professional groups and general public community, other government bodies, etc. We had to get in touch with them. And this coordination was very important at that time. And I hope that has to be continued. The call for the voluntary services from the person, and we, as we said earlier, the lack of availability of gadgets and other network things were very difficult. So we had to get in touch with the voluntary people, voluntary service people, and we had to know about the people who were not able to get the services. We had to get in touch with them, or they should be made into connection with the other people who are having the gadgets and other services. Next slide, ma'am. The multidisciplinary rehabilitation method had to be followed. We were not, multidisciplinary rehabilitation method had to be followed. Mainly, many children were taking services from different centers, but when they came into a same group, we had to refer them to each therapist, and the timing and all those things had to be arranged. That was a challenging thing at that time, but we had to manage it. So we were recording we were collecting the data, and we were recording the services that were given to each child, listing the therapies given by the therapist to prevent the overlapping of the home program given by the therapist, the follow-ups by the therapist on the home program that has to be timed. All these things had to be recorded, and the case pattern has to be recorded. The case distribution, again, I'm coming to the work of the liaison officers. The case distribution was a main thing that has to be done according to the availability of the therapist, the timing of the therapist, number of references that has to be given to each therapist, the need of multiple therapies that has to be given to a child. All these things was a difficult thing, and that was coordinated at that time. The urgency of the intervention, that has also to be noted at that time. And the formation of the job pattern, the same thing. Next slide, ma'am. The formation of the job pattern, as I said, the number, the agency, the availability of the slot, and all those things had to be done. The daily report pattern has to be done. The parental feedback had to be done. And next slide, ma'am. The involvement of the authorized government body was important, and we were doing the tele-rehabilitation under the district collector, the tele-rehabilitation group, and we thank the district collector and the other who had cooperated and the agencies that had cooperated with us during the pandemic time. Thank you, Department of Psychology, for the opportunity of the presentation. Thank you.
Thank you, Denny, for this wonderful presentation. So we'll be moving to the third presentation. So the third presentation with Shaniba J T, Special Educator, Vocational Rehabilitation Specialist. She'll be talking about the special program for young adults with disability during the COVID-19 pandemic. Shaniba, over to you, please.
Presentation. Good morning, all.
Yeah, Shaniba, you're audible, please.
Okay. Special program for young adult with intellectual disabilities during pandemic. Today, I'm standing here to deliver my professional experience as a special educator during the pandemic. I would say that it's very difficult and at the same time a very new learning experience for me. Next slide, sir. Slide. As you all know, first point, pandemic have been a large threat to the survival of human being. Pandemic that crossed all the geopolitical boundaries was this threat at global level. Second, the most recent pandemic of human history, known as the COVID-19 pandemic, has been different than previous pandemic witnessed by the human race. Since outbreak in November 2019, graduate rising cases day by day, and the death of toll of COVID-19 has gone up to million. There has been a surge in scientific studies exploring the impact of COVID-19 at various aspects of life. The researchers have identified main themes of fear of COVID-19, centered of fear of having corona, fear of death, fear of loss, fear of isolation and quarantine, fear not knowing, and fear of inactivity, etc. In the course of pandemics, the vulnerabilities of certain groups of people have been highlighted, such as the elderly, pregnant women, and the homeless. However, less attention was given to people with intellectual disability. Meeting the need, they protect people with intellectual disability from infection, and to support those infection is a talent to care services often, because the unique characteristics of people with intellectual disability to adapt to new circumstances. Next slide, sir. The major challenge was addressing the fear of COVID-19 among adult disability, intellectual disabilities. First point, fear, lack of awareness. Social media discussion and news were unable to follow by the adult with ID. Created videos, materials to increase their awareness. Lack of communication, lack of opportunity to interact with multiple people during this period. There was a lot of myths were identified. This has led to limited exposure and limited them to access information from social media. Increase in death rate. It is believed that COVID-19 can cause sudden death in people with physical problems. During the second wave, when the mortality rate has increased, they have started become anxious because they are aware about their medical comorbidity, such as epilepsy and psychiatric problems. Next slide, sir. Anxiety. It is a matter of concern that persons with disabilities have been forced to confine themselves with the four walls due to the COVID-19 pandemic, which restricted their normal life. And availability evidence-based treatment of COVID-19 has increased their anxiety. Change in their routines. Change our routines. Exercise, diet, and lack of exercise, and malnutrition and physical alignment. Next slide, sir. Next slide, sir. Behavior issues, disobedience and anger resistance. Due to restricted activities of daily living in a residential setup or within the ward, communication, friends, routines, vocational training, education, leisure time, etc. Loneliness, self-talking, increased sedentary behavior and screen time, such as television, computer, or smartphone use. There is the challenge of we have faced. Next slide, sir. After discussion with multidisciplinary team, we have come up with the following remedial measures. Prepared effective videos and audios related to appropriate awareness COVID-19 suitable for them. A virtual training program was organized involving multidisciplinary team to address the issues of parent and adult with intellectual disability. We have started tele-rehab program, especially parent-mediated training. We have taught them how to use technology to connect with their loved ones. Zoom and Google Meet, WhatsApp videos, voice record, etc. Next video, sir. Provider, next, sir. Next slide, sir. Next slide, sir. Provider awareness program about COVID-19. Slide. Okay, thank you. No, sir. Home visit and medical assistant by the professionals. Next, provider peer group support group. Provider peer support group created. Program and communications. Next slide, sir. Next slide, sir. Training program.
Excuse me, Shaniba, we are changing slides. There will be a slight delay to, see it on the screen. Okay?
Okay. Next slide, sir. Take a look in these photos. Microgreen Paddhati. Different type of training program. Microgreen Paddhati. Next slide, sir. Okay, ability hygiene, hand wash making. Next slide, sir. Next. Gardening. Cookery show. Craft work, new materials. Use the new materials. Household activities. You created the children bottle arts. Next slide, sir. Cultural activities in home based. Birthday act celebration, Onam celebration. Next slide, sir. Horticulture therapy. Handicraft management of waste management. അപ്പൊ ഇവിടെ ഇത്തരം കാര്യങ്ങളൊക്കെ അവര് ഈ സമയത്ത് വീട്ടിൽ നിന്നുള്ള അവരുടെ ആങ്സൈറ്റി, ഫിയർ, അതേപോലെയുള്ള അവർ ഫുൾ ടൈം എൻഗേജ്ഡ് ആവുന്നതിന് വേണ്ടിയായിരുന്നു CDMRP അഡൽട്ട് ഇന്റലക്ച്വൽ ഡിസബിലിറ്റിയുടെ മേഖലയിൽ ഇത്തരം പരിശീലനങ്ങൾ നൽകിക്കൊണ്ട് അവരെ മുന്നോട്ട് നയിക്കാനും പ്രചോദനമായിട്ടുള്ളത്. അവര് മുന്നേ നടത്തിയിട്ടുള്ള പല ഫിസിക്കൽ എഡ്യൂക്കേഷൻ ആയിട്ടാണ് നൽകിയിട്ടുള്ളത്.
Okay. Thank you, Shaniba. I think she had some network issues. I think if you have any questions regarding this, we will discuss during the discussion session. I think we have another fourth presentation, Dr. Mridula. So I'm happy to invite Dr. Mridula for presenting her experience. She'll be presenting about the topic of caring the children with a special need during the pandemic, a caregiver experience. Ma'am, welcome.
Good morning, all. So
Good morning, madam.
you
You're audible. Yeah, you're audible. Please.
Good morning to all. As we know that this pandemic has created as a unique challenges for the children with the children with disabilities. Just one second. Hello, am I audible?
Yeah, ma'am, you're audible now.
Some network issues, that's it.
Okay, please continue.
This video is available. Video available.
Ma'am, if you face
Hello?
any network issue, you can switch off your video so that you get a good bandwidth.
Okay. Fine.
Yeah, please continue, ma'am.
Is it available? Video is available now? Oh, yes, okay. Yes. Good morning to all. This pandemic, as we know that this pandemic has created a unique challenges for students with disabilities and their families. So I'm here representing as a parent, and I have a son. I'm a mother of the child diagnosed with ADHD. I would like to uh, I would like to talk about some experience during this pandemic period. Actually, I'm started the therapy sessions in CDMRP for my son, and later again I shifted to CALICUT for conducting therapy from more centers. Like me, the other parents also conducted therapies in different centers. But what happened is during this COVID period, this systematic manner has stopped, and this, the therapy centers are closed. So our children, they are going. We can't continue this. We can't continue therapy sessions, and in the during this COVID period, we are facing the main problem is our public using public transport, because as we know that during this COVID period, we have created some restrictions and some protocols. But these children, they are not follow these protocols. They are not wearing mask, and they are not sanitize their hands. So in this situation, it is not easy to transport them in public transport. This is one of the main issue we are faced in COVID period. And another problem is that the closure of our institutions. The institution are closed for 1.5 years, so they are not getting any therapy in that during that period. And now itself also, if it is restarted, maybe it may be closed for one some COVID issues. So this during this period, it is very difficult to handle these children. And one of the another main issue we are facing is online sessions. That is, in online session, as we know that in normal students also, it is very difficult to follow online sessions. So in this these children, they are struggle, they are, it is very difficult to handle these children to get into their attention into they are not cooperative this online sessions. So the online sessions is not at all effective for these students. This is the main issues that was faced during this COVID period. So in this period, the total the therapy was stopped because this some of the parents reported that it is very difficult to stay this children in homes, because they are restricted in their some place. So they have not get any social explosion, and they may their behavior was changed, and they misbehave, that they are always fighting, and maybe is their aggressive behaviors. All these problems are occurred in this COVID period. Some of the parents, so, uh, parents tell me that their children, they are destroying some electronic products, and the windows are breakdown. All these things are done with their children, because they are very highly frustrated in this period. Uh, and the our another main issue was in this period, COVID period, all the family members are there in their house. Family, it is very difficult to handle this this children, because they are hyperactive behavior is not at all It's not like other family members. Maybe some other family members is not cooperative with this parents. So the parents may become they become depressed. In these issues are happen in the COVID period, in lockdown period, especially in lockdown period. And most of the parents they are shifted to rented houses in for nuclear for living in nuclear family, because it's very difficult to handle their uh, children in these situations. And other as per in are giving different online sessions, but I have an opinion that it is not it is more effective when we give it in when we came to when we go to their homes of their children, and we give therapies, be more effective. And in again the main issue regarding the just physiotherapy issue students, because they are in that period they have no some machineries or some machines to practical training for these children. All these are the main issue we are faced in COVID period. And I have some suggestion that we need more things to build up their career, because we need more good educational system, because we are following in the normal education system in the students. So it is very difficult. So in this period we are identified that it is very difficult to handle this children. So may in future days we may face these situations, and other pandemic diseases may be other diseases may come. And so I have one suggestion that in each ward we can select a special educator, and can conduct class or can observe the disabled child. Hello, am I audible?
Yeah, ma'am, please
Hello?
continue. Yeah.
Yes. These are your experience. So I'll conclude my speak. I especially thanks to Dr. Remshida. She translated my speak, and a special thanks to Raheemudheen sir for inviting me to this wonderful session. And a special thank to all CDMRP members. Thank you, sir.
Thank you, Mridula. So we'll be going to the last section. So I would like to present my slide. So someone please help me to share this one. Can you make me? Could you please make me the hello the presenter?
Hello.
Hello.
You want us to present a PPT for you, or
Yeah, I'll be presenting from my side.
you will be presenting, right? Okay.
So someone has to give the presenter option. Yeah, thank you. My side is visible.
Yes, sir.
Yeah, thank you. Good afternoon, all. Most of the my previous speakers have already discussed the very detailed what are the different activities done by different agencies during COVID-19 pandemic in response for the empowerment of person with a disability. As the last section, I'll keep my presentation very brief and short. So, as you know, that COVID-19 pandemic has created numerous challenges to the life of person with a disability. The various international and national agencies have done a few studies and very few studies, and also they have shared the experience from from their review of literature and their studies, and also from our last 2 years clinical experience working with a different level. So I have identified a few challenges faced by a person with a disability. Person with a disability have a limited access to the community resources. They have a difficulty to understand information related to COVID-19, such as the various preventive measures, the various SOPs for practicing the preventive measures, hand washing and social distancing and mask. Due to their inherent difficulty for the communication, they have a difficulty to express their symptoms and distress. And also, most of the person with a disability experience different healthcare needs, and they have a different comorbid issues. And many of the PWD do have specific underlying condition that make them more vulnerable for getting infection. That's create a more dilemma and confusion among the parents and the caregivers group. So, as we already discussed few best practicing model in the area of disability inclusive response for COVID-19. So, UNESCO and UNICEF and other international agencies identified what should be the goal of a disability inclusive response, because it should be, because the COVID-19 situation will be continue for in another 2 3 years. So we need to have another more activities. So the goal should be to ensure the mainstream of a person with a disability and caregivers in COVID response together for target action. Second objective to ensure the accessibility of information, because all type of information, and when we talk about the disability, we need to consider that disability is a heterogeneous term. A person with a disability, person with intellectual disability have a different level of capacity as compared to other type of disability. So information has to be adapted to address the need of different person disability. The information facilities services has to be adapted to in the to address the unique need of person with a disability. Also, this program should ensure the meaningful and active participation of person with a disability and caregivers in all stages of COVID-19 responses. And also, we need to address the unmet need of person with a disability. Generally, when we talk about the disability inclusive policy, we talk about only the education and health. Apart from the education and health, they have lot of other needs. Their emotional need, the social need, the need for social interaction, need for social affiliation, and employability also to be addressed. And it has to be need sensitive. Apart from the education and health, we need to be focused, and we need to design the program custom made and tailor made program to address the need sensitive and age sensitive and gender sensitive program. So this has to be the goal of the program. As most of the previous speakers has very extensively present this various innovative activity done during this COVID-19. During the initial period, the major challenges we face that most of the parents has dilemma, concern, anxiety. What will be the next step? What will be the anxiety to address the psychosocial concerns and mental health concern? Under the direction of a state government, district social justice department has started a tele helpline. Under this tele helpline, with the collaboration of a different LSC, we have started a tele helpline to mainly be provided initial supportive crisis management section and collaborative section and supportive section, and the Rasha workers also supported to identify the various issues. Secondly, as you know that COVID-19 is a very new phenomenon for us. There was no proceedings, there was no prepared plan for this. As a crisis, as a first response, and we are so happy and proud to share that under the under the CDMRP Department of Psychology, we came up with a wonderful module called it's called Life in the Time of COVID, and we have published this module with the support of UNESCO New Delhi office. And this module has published in 8 international languages, Spanish and other French and other languages are available, and also Mexican Sign Language also published. So this module generally address the various concerns of parents. We talk about the standard hygiene practice, adapt sign language hygiene practices, food habit during this COVID-19 pandemic, medication, exercise, sleep, home-based training, and school psychosocial well-being. This module is still popular, very extensively circulated all over the India, and also it has been used in many international and national agencies for the part of their COVID-19 pandemic. The secondly, as you know, the most of the person with a disability, particularly the person with intellectual disability, have a many comorbid issues such as epilepsy, multiple disorder. To ensure the continuous availability of medication, the as a very important crisis. Under the District Social Justice Department, we have started a Medi-Chain program. So there, ASHA workers and Angalawadi workers and other community workers uh, regularly monitoring the person with a disability. If they have any medication need, so they are, with the support of district DMO and other agency, we provided medication. Around 3,000 3,000 person with a disability has benefited the scheme. It was one of the key, like one of the very prompt act from the side of ministry. So another flagship program initiated by Department of Psychology, CDMRP. So we have started a program called Veedu Vidyalayam. As a collective program, we started a integrated homeschooling program for children with intellectual disability during COVID-19 program. Under this Veedu Vidyalayam program, CDMRP has proposed, implemented around 8 different programs. It include tele-rehabilitation program. There, Mr. Denny Davis has extensively explained about that. We have developed very different video home program videos, pre-distribution of 3 TLM kit and psychosocial support crisis hotline, home-based horticulture, Shaniba already explained, and different other guidelines also we published. So as Denny Davis already explained the tele-rehabilitation program, because as you know that COVID has been like this lockdown has imposed in March. The very next week, April onwards, we have started the tele-rehabilitation program. We can say that the CDMRP is one of the agency has initially introduced the tele-rehabilitation program. We can see the news coverage of NDTV. NDTV has given a coverage about CDMRP tele-rehabilitation and way back to 2020 April first week. So we have utilized this multidisciplinary approach to tele-rehabilitation. Apart from this well sophisticated tele-rehabilitation software, to address the unique need of person with a disability from even the remote area, we use different modalities, phone, WhatsApp, Skype, and all other in an integrated manner. So we have also developed a systematic operation network, how we should conduct a cost-effective and integrated tele-rehabilitation method. So it would be a very replicable model for other areas also. So, and apart from this tele-rehabilitation model, we have developed many form program videos, worksheets, handbook, and WhatsApp discussion groups. This has been very useful for the person with disability in some sort. So Denny Davis already explained this one. We have developed around 64 videos. Our CDMRP team has a very vibrant team. They have within a short span of period of around one month, they have developed around 62 videos. It's available in the university website and CDMRP YouTube channel. And also we have developed a few intervention modules available freely available in the university website. And one of the another important thing, as you know, the most of the people are staying in the home. They needed some therapy equipment. They needed some assistive devices. So how we get this one? As you know, CDMRP is a community approach method. So in collaboration with the National Institute of Empowerment of Person with a Disability (ADIP) scheme, we have started a TLM distribution camp. So in the last 2 years during this pandemic, we have distributed around 3,500 kits. Each kit costs around 8,000 to 9,000. So apart from the distribution of the kit, we started training and also it was a complementary to their other tele-rehabilitation and whiteboard activities also. So another important continuous activity in continuation with the CDMRP activity, from the inspiration of this activity, state government has started one of the massive voluntary network program. It is a Sahajivana program, and CDMRP was given the charge of training of these volunteers. Our liaison officers and other faculty members have given a very extensive training for these volunteers. We have trained around 3,000 volunteers across the state. And so these volunteers will be the part of a continuous regular system under the Department of Psychology, Department of Social Justice Department. As the Department of Psychology has given academic input, these volunteers will be addressing their unique need and their continuous need, even after the pandemic. So the Honorable CM is closely monitoring the progress of Sajivana program. So these are the major best practice model happened during this COVID-19, particularly in the Kerala. As you know, we need this is COVID-19 situation not at over. We need to have some proactive step to this disability inclusive. Already we have explained few methods. This disability inclusive initiative could address only the immediate need of a person with a disability. We could not address that long-term need. But to address the long-term need of person with a disability in new normal life, we need to have a more proactive and sustainable and comprehensive right-based intervention strategies. Further, we need to have addressed the unmet need of a person with a disability, such as psychosocial concerns of caregivers, adequate opportunity for social inclusion. Disability inclusive program should be an integral part of all future initiatives. Yeah, as we know, this COVID has given a lot of paradigm shift for our thinking and policy making and academics. So, disability inclusive program should be an integral part of all our future ventures, particularly the like policy making for policy making. So, in future, the various activities need to be scientifically prepared to implement to implement with community participation in order to create a disability friendly society. Intervention should be designed at a different level. It should be individual level and family level and community level. So it has to be evidence based. So psychology students can be actively involve the research process, and they can design their custom made and tailor made intervention strategies to address their individual level and family level challenges and possibilities. To ensure the disability-friendly attitude, we need to provide adequate opportunity for social participation. So even though there are a lot of restrictions for the active participation, we need to create a very scientifically informed and evidence-based opportunity for social participation and also inclusion in all sectors of community. We cannot limit the inclusion into the merely into the education and health. We need to provide adequate and possible opportunity for social inclusion. At the same time, we need to address the mental and physical and financial well-being of caregivers because they are they are another one of the vulnerable group. We need to address their concern also. So it is important to understand. It is our duty and it is duty to create a disability-friendly new normal life. So disability friendly new normal life should be our priority and it is essential for any civilized society. So with this, I'll conclude my session. So thank you all participants. So we'll be opening for the question answers and your comments and your sharings. Okay.
Mr. Anilkumar, Mr. Denny Davis, Mrs. Shaniba, and Mrs. Mridula for sharing your personal experiences working with children with special needs during the time of pandemic. Actually, from yesterday onwards, we are listening to the impact of pandemic on different areas of life, but definitely this session was an eye-opening one because this shows the amount of hard work, effort, and commitment each one of you had to put to make all these things happen. So it was really challenging, as it's very evident for all of us. Thank you once again for bringing it for us. Next, we are moving to a question answer session. As we are running out of time, I'll just read some of the questions and panelists can answer. Can I start?
Nidhu, if is there any specific questions specifically addressed to any panelist, you can address to the particular panelist.
Okay, I'll read them first. Okay.
So all panelists are available now. Okay.
Yeah. There is one question to Anilkumar sir. Using online platform for the first day must be difficult for parents, right? Then how did the team address such issues related to digital literacy?
Anil sir, are you there?
Okay.
Yeah.
We have given training to parents through Jalagangal Kapram program. We have actually it's a practical training. We have conducted a training program to express the talents of their words, their songs, their dance, their dramas, etc. are shared on the online platform. So we have taught them how to use Google Meet platform, Zoom platform, how they can present the videos, etc. In the practical sense. So they have already they are in one through one or two sessions. They are very familiar with using the Google Meet platform and all these things. And through WhatsApp platform group, so small WhatsApp group are also used. They are familiar with the WhatsApp group. And main problem is for getting the videos that have already distributed or shared through the YouTube channel. While they are getting too much time for downloading, so the parents doesn't know what's happening there. Is it downloading or is it available or any other issues? So that created the problem. But in using the Google Meet platform and Zoom platform, they are familiar. But downloading the videos from YouTube channel, they are not so much familiar because due to the lack of proper network speed.
One more question for you. It's about the unemployment of parents. It's written that unemployment of parents and the associated financial issues might have created a lot of issues for children for receiving continuous professional help. So in such cases, was there any kind of financial support from the government for either for children or for parents having children with special needs?
We are giving girls stipend to every differently abled children. It's 2,000 rupees per child, and we are giving transport allowance and escort allowance to the selected students. And actually, the services given by government is cost free, and we are giving therapy to every needy children. Physiotherapy and speech therapy. Those who need physiotherapy and speech therapy, they can approach our special educators. Definitely, they will get therapy in the post without paying any without any payment. They will get it. And occupational therapy, we are not providing due to the lack of availability of the professionals. And every other thing is giving free of cost. But maybe they talked about the net recharging problem. We are not providing the financial support for recharging the net. The parents have to recharge from their own funds.
Thank you, sir. There is one question for Shaniba. Shaniba, ma'am, you said that some clients had a myth that people with physical problems could die if they were exposed to COVID. Studies says that patients of higher age and with pre-existing chronic health conditions are at an increased risk of fatal disease outcome. So how can we say that it's a myth?
അതെന്താന്ന് വെച്ചാല് സാധാരണ നമ്മുടെ കോഴിക്കോട് മലപ്പുറം ഈ ഏരിയകളിൽ നിന്നാണ് കൂടുതൽ വിദ്യാർത്ഥികൾ വന്നിട്ടുണ്ടായിരുന്നത്. ഇത്തരം വിദ്യാർത്ഥികളുടെ ഇടയിലാണ് എനിക്ക് വർക്ക് ചെയ്യാനുള്ള അവസരം കിട്ടിയിട്ടുള്ളത്. അപ്പോൾ അവിടെ നേരത്തെ ഒരു നിപ്പ വൈറസിന്റെ ഒരു പാൻഡമിക് നടന്നുകൊണ്ടിരുന്ന ഒരു ജില്ലകളാണ്. അപ്പൊ അതുകൊണ്ട് തന്നെ അവർക്ക് ഇത്തരം ചിത്രങ്ങളൊക്കെ കാണുമ്പോഴും അവർക്ക് ഈ ഭക്ഷണ സാധനങ്ങളിൽ നിന്നാണോ ഈ അസുഖം പകരുന്നതെന്നുള്ള ഒരു സംശയം ഉണ്ടായിരുന്നു. അങ്ങനെ പല രീതികൾ, കാരണം സാധാരണ ഉള്ള മീഡിയകളിൽ നിന്നും കിട്ടുന്ന അറിവുകൾ അവർക്ക് അതേപോലെ തന്നെ സാധാരണക്കാർക്ക് മനസ്സിലാവുന്ന തരത്തിൽ തന്നെ അവർക്ക് മനസ്സിലാക്കാനുള്ള ബുദ്ധിമുട്ടുകൾ ഉണ്ടായിരുന്നു. അപ്പൊ പല സംശയങ്ങളും അവരുടെ ഇടയിൽ കടന്നു വന്നിട്ടുണ്ടായിരുന്നു. അതായിരുന്നു അതിൽ കൂടുതൽ ചർച്ച ചെയ്യപ്പെട്ടിട്ടുണ്ടായിരുന്നു.
Hope it is clear. There is one question for Mr. Raheemudheen. How did children with special need accepted the online mode? What was their initial response and how did you manage?
Sir, you are not audible.
Raheemudheen.
Sorry. Okay. So addressing this question, because Anis are already addressed this question, but for addition to that, so as we know that in initial period of the COVID, in the month of June or July, the government has started education department has started a like a first bell program. Their students have started online training, online classes. From that day onwards, most of the children with disability, adult children with disability, started asking when our class is going to start. We also want to start the classes. So initially, we have started the program with the help of parent mediated. As Denny Davis already clearly mentioned, we didn't given the training to the children directly. We have given training to the parents first. So with the help of the parents, we have started. We have given the training to the children. So directly giving the training for children with a disability will be very difficult because their comprehension level, their understanding level, then most things that their attention level, attention span will be very limited to for these long classes. So we have followed the integrated method of telerehabilitation and education, that is parent mediated method. So the hardcore telerehabilitation will be very difficult for the children with intellectual disability, particularly children with autism and the ID. So we have given the training to the parent mediated approach. Okay.
There's just one more question. This is to the therapist, Denny, Shaniba, also to the parent, Mridula, and Raheemudheen also. As practitioners and parent, do you think that there will be a change in the relationship between the parent and professional post the pandemic when you get back? Do you, I know CDMRP is already doing parent-mediated approach, but in general, do you think there will be a change in the way the relationship is going to function?
Can you address this question?
Yes, please.
When I started doing the parent mediate thing, anyway, when the parents are giving the therapy, the tantrum and the behavior of the child is different than when they are mingling with us, with the therapist. So, however, whatever methods the parent try to do that, there will be a lot of corrections that we have to do at the end. So, the acceptance with the children is always, it has remained the same always as before only. There weren't any much difference that I had seen, like even just after the class I had to go to the child, a parent had come with their child. So the level of therapies and the methods that we are using, the therapist is doing for the intervention, and when the parent is doing that, there is a hope you can understand there will be a difference. So that is always kept as a different approach only for the child. So the level of acceptance has not much changed. It is all the same for us as far as I have felt. Thank you.
I have an opinion.
Yeah, Mridula ma'am, please go on.
I think most of the children are not accepted. നമ്മളൊരു therapy ചെയ്യുന്ന സമയത്ത് അവരത് accept ചെയ്യുന്നില്ല എന്നുള്ളതാണ്.
Yeah, you are right, because their parents have a double role. One time they'll be acting as a parent, and same time they'll be acting as a therapist. So
We are always with them. That's why.
Yeah, but Denny, please.
Behave like to do it in a play therapy mode. Never the child should feel that they are into a therapy session. So the level of the parent remains the same, and the child is only involving in a play game with the parent. That will make them easy to achieve the target, and even for the therapist for maintaining their target. So as a therapist, I am not expecting the parent to be a therapist, even though we are trying to give the therapy sessions through them. Because in a community setup, when the larger group of children are coming, we are unable to give necessary sessions or a daily session basis. We are unable to give for each child. So what we use is we involve the parents in the therapies. So when it comes to the parent mediation, we tell the parents to do it in a play therapy mode, mainly in children with 0 to 5 years or something like that. We do it in a play therapy mode, and above then when they start to understand what they are doing, we make the games into a different level, so the children is still playing at their home. So through that games we try to achieve the targets. That will be easier for the parent, because when they give a game to the parent, even the parent can be free, but the child will be interested in doing the game. That's what we try to do. It's the method of understanding between the parent and the therapist.
Okay, thank you, Mr. Denny. Okay, I think we have addressed most of the questions and we can wind up the session. Once again, I would like to express my sincere thanks and gratitude to team CDMRP, and it was really a wonderful, informative session. Once again, thank you all.
Thank you.
Thank you.
So enjoy your meals and kindly join back by 2:15 p.m.